Good morning, everybody. On behalf of the Ceylon College of Physicians, I would like to invite and welcome you all for the specialty update in cardiology. And I am Dr. Shamita Dasanayaka, Secretary to the Ceylon College of Physicians. And my co-chair is Dr. Anindhu Pathirana, the President of the Sri Lanka College of Cardiology. And this month is dedicated for cardiology. And we had two events. One is the college lecture, and we had the expert webinar in cardiology with the collaboration of the Sri Lanka College of Cardiology. And today is the third event, that is the specialty update. And today we had 4 speakers. Then may I cordially invite Dr. Anindhu Pathirana to introduce the speakers for today's session.
Thank you, Shamita, and good morning to all of you. First of all, on behalf of Sri Lanka College of Cardiology, let me thank the President and the Council of Ceylon College of Physicians for arranging and inviting us for this specialty update today in cardiology. So it is my great pleasure to introduce the first speaker of the day, Dr. Asanga Dunuvila, Consultant Cardiac Electrophysiologist at the National Hospital of Sri Lanka. And he's been the first board-certified cardiac electrophysiologist. He has done a lot of work to develop a high-quality cardiac electrophysiology service in Sri Lanka. I think we must all of us should be thankful to him for that innovative work and later developing it to a very high-quality service. And today he is going to talk about what a cardiac electrophysiology can offer to a patient. Over to you, Asanka.
Thank you very much, Anindhu. Good morning, my colleagues, the representatives from College of Physicians and our virtual audience. I think it's rather strange to speak to an empty audience, but also realizing the fact that somebody is watching you from far sometimes makes you a little nervous, but I think we'll all have to get used to this. The topic I'm going to discuss today is what cardiac electrophysiology can offer to a patient. Before I actually get into the topic, I thought a few words about where electrophysiology originated from, how it all started. We have a short history of 50 to 60 years where like certain innovators realized that heart also has electrical system which needs to be handled separately. So they started investigating into bradycardias and tachycardias in early 1960s and then progressed quite slowly up to about the mid-1980s till the therapy was introduced. Then it diversified in a way that by early 1990s the therapy was well established and progressed quite quickly to the level that we are practicing right now. So when you talk about the scope, we can divide into different areas. So I thought it's appropriate to discuss things under a few headings. So first of all, management of syncope, followed by our main areas. We are identifying and treatment of cardiac rhythm disorders in nature of tachy as well as bradyarrhythmias. Then a very important area of identification of sudden cardiac death risk treatment and conditions related to it. Then the heart failure device therapy, and important topic of management of atrial fibrillation and stroke prevention related to it, and then a few words about future trends. So the important area of management of syncope first needs evaluation properly. We overlap here with neurologists, physicians and cardiologists. As most of us know, syncope is initially handled by a neurologist. That's the general perception that the patients have. So they do visit neurologists because the most commonly known condition is epilepsy. Right? Then patients do get referred to us first sometimes to the physicians. Right? So here, when you look at syncope, the most important thing is to handle the history and clinical circumstances where syncope occurs. So if we shorten it, syncope is least affected in between 30s and 40s. At either age, in childhood and then with increasing age, it rises. Right? Basically, need to differentiate between vasovagal syncope, which is a common benign type, and arrhythmic syncope, which can have mortality issues. And then whether heart disease, structural heart disease is promoting it, in which case it increases the sudden cardiac death risk. And then, of course, we need to address the morbidity. So it's important to get to a diagnosis. So from the cardiac point of view, ECGs sometimes offer a clue, but most of the time it doesn't. And then we progress through several steps to Holter monitoring, exercise ECG if needed, tilt table testing, sometimes internal studies of SA and AV nodal function, provocation testing, and long-term monitoring. So we might get a diagnosis at each different stage, in which case one can proceed with the management. So few things about the initial thing is generally asked for, and what we normally do is a Holter monitoring test. Shown two diagrams here, a child as well as an adult with a Holter monitoring. Very useful test for frequent episodes, but not so useful when the symptoms are few and far between. The yield is about 14%, and if symptoms happen once a week, roughly. So sometimes, like we used to do this much more often earlier, but we don't do this often now. We do internal studies to analyze the SA and the AV nodal function. So for example, if you do internal, the catheter-based stimulation study called sinus node recovery time, the certain findings will indicate exit blocks and heart blocks. So this is an example how sinus node recovery time is prolonged to suggest sick sinus syndrome. Implantable loop recorders have come very, very strongly into play, and initially they were little larger than this. Now you can see it can be demonstrated in the palm of a hand. It's that small, and then this particular gadget is implanted through a special mechanism subcutaneously, and it's very important for undiagnosed syncope. So because this device can be kept for more than a year, sometimes even up to 3 years, the modern ones, so that the rare events can be recorded and the diagnosis can be reached. And the only problem with the loop recorders, implantable loop recorders, is the cost. Like when it comes to a developing country, they are very costly. Tilt table testing, if you suspect neurocardiogenic syncope, we would perform a tilt table testing to confirm the diagnosis. You have to select the patients quite carefully for this particular testing, because it can also generate false positive testing. So therefore, you get the basic keys from clinical history, and then if the ECGs is normal, if the echoes are normal, and then you can proceed with the tilt table testing. A good example for that, what you basically do is there are several protocols. You have a resting phase and a tilting phase under intensive monitoring, and if syncope is developed at this time, you could record the findings. A good example how it would work in vasovagal syncope, where the top half of the ECG shows a sinus rhythm, which is a little bit sinus tachycardia. As the patient starts feeling syncope, some kinds of heart blocks developing, and then right at the bottom you see a long pause. And so this will diagnose a vasovagal syncope is predominantly cardioinhibitory pattern. Carotid sinus syncope is another example which need not have a tilt table test, but better it can also be identified by pressing the carotid sinus under intensive monitoring. And so that's an example of that. So then if you have to take a step forward, in syncope, the bradyarrhythmias come into play. So a segment turns out to be bradyarrhythmias. Then how does one handle it? Initially, bradyarrhythmias are divided into two particular areas: sinus node dysfunction and heart block. As you know, sinus node dysfunction is SA nodal disease, heart block is a problem along the AV nodal disease. Now, the majority of these conditions are degenerative, but some can be congenital. You will also look for correctable causes like ischemia or drug induced, and few of them we can find those causes, but certainly at the elderly age group we find the causes are permanent and then treatment is needed. Example of sinus node dysfunction, the initial part of the ECGs show severe bradycardia, and then towards the latter side also a tachyarrhythmia is noted. So this is a sinus node dysfunction, tachybrady variation, because of the if the patient has symptoms, one would need pacing as a definitive therapy. Heart blocks, where more P waves than QRS, you have resting bradycardia. It's quite clear that the patient needs a pacemaker to avoid sudden cardiac death. Congenital heart blocks are handled slightly differently to adult heart blocks. We have a lot of reservations pacing a child, knowing the fact that if you put a pacemaker, it's going to be a lifelong treatment. So there are a series of things that we would take into consideration before putting a pacemaker to a child. I have highlighted those, particularly the symptoms, the resting heart rate, LV dilatation, and the general function of the child. Those are taken into consideration. And if we find that some of these things are unacceptable, we would go ahead and put a pacemaker in. In a child, the hallmark is try not to pace. Try not to pace, and pace only if absolutely necessary. So, when it comes to the management, any temporary condition may be reversible. You always encounter patients with ischemic heart disease, probably with inferior MIs, with heart blocks. So those things ease off. You only need temporary pacing for a short period of time. Otherwise, you go ahead with permanent pacing if the condition is permanent and it's producing symptoms. As a procedure, pacemaker implants are generally quite safe, and complication rate is less than 1%, which include pneumothorax and cardiac tamponade. Infections can be a problem, especially in the reimplants. Few examples of permanent pacing. You can see a pacemaker wound of a patient on one side, and on the other side a dual chamber pacemaker which is being implanted. And the lead positions have changed over a period of time. It has moved from right ventricular apex down up to the septum, and now even a little lower down. But the septum is a preferred site to give better electrophysiological output. There are always guidelines for pacing, and there are a lot of guidelines, but basically if a patient is having bradycardia and if it's related to symptoms and the condition is non-reversible, we'll go ahead with pacing. Right? And so in sinus node dysfunction, there may be other categories which may need pacing. Like for example, somebody's resting heart rate is good, but there is severe chronotropic incompetence. So that also needs pacing to get over the chronotropic incompetence. Sometimes at the certain age group, there is coronary artery disease as well as bradycardia. So if you provide bradycardic therapy, coronary artery disease also can be handled much better. So that's another indication. So likewise, there are certain indications of pacing, but the hallmark here is symptomatic bradycardia. Then you move to tachyarrhythmias. Supraventricular tachycardia and ventricular tachycardias are the two different types of tachyarrhythmias. The supraventricular tachycardia, the majority are either AV nodal reentry or WPW related tachycardia. It's a condition that can lead to a lot of morbidity. There is certain mortality also associated rarely with things like WPW syndrome. So, so they should be offered particular therapy. Ventricular tachycardia and ectopy, especially in the Asian region, has normal with normal heart structure, but certain varieties of ectopics and tachycardia, such as outflow and fasciculum. A common SVT, I think all of us will recognize this, a narrow complex regular tachycardia with hardly any P waves being seen. So this is a AV nodal reentry. Just to quickly highlight how a WPW works, right at the start, why the pre-excitation occurs. In the first diagram, when the impulse moves through the AV node as well as the accessory pathway, a delta wave and a short PR is generated. When tachycardia occurs, it works either down the AV node up the pathway or in the reverse direction. And this antidromic tachycardia can degenerate into atrial fibrillation, and that is where the sudden cardiac deaths can occur. Evaluation of tachyarrhythmias, again symptoms are the key, but ECG is the one which gives rise to the diagnosis. Holter is only needed if the symptoms are frequent or but diagnosis is elusive, and if one has to analyze ventricular ectopic burden in somebody to decide on therapy. exercise ECG is important in certain situations. Holter should not be done blindly. It's helpful if the ECG is diagnostic, there's hardly any point in doing Holter, but otherwise it can adapt to the diagnosis. In acute presentation of SVTs, we know that one needs to give AV nodal blocking drug, either adenosine or verapamil, and if hemodynamically unstable, electrically, patient needs to be cardioverted. In long-term management, for the past 25 to 30 years now that the radiofrequency ablation is in place, it should be provided. It's a class 1 indication as a curative therapy. Medications are an option. It's suppressive, but it's non-curative. Sometimes it is as good as a cure, but most of the time it is insufficient. So, general success rates of supraventricular tachycardia ablations, the common varieties give anything up to 90 to 95% success rate with a very low complication risk. What is worthwhile mentioning is 1% risk of AV nodal damage in certain tachycardias like AV NRT. I think it is now even 0.5% by using the techniques that is available. Normally, short hospital stay done under local anesthesia and sedation. The intervention is done through venous access mostly, and if arterial access, if pathway is left-sided. So, example of catheterization and catheter placement, and how it looks under the fluoroscopy. And so that's how a normal supraventricular tachycardia ablation would go. Ectopics, a very common issue because we see a very high percentage or high prevalence of ectopics in South Asian communities, especially the outflow tract ectopics. And sometimes the ectopic burden is not high, but the patient is symptomatic. But mostly the number of ectopics correspond to the burden of ectopics, and then this needs to be analyzed to diagnose the type of ectopic, symptoms, frequency and burden, and LV dysfunction. And if some of these criteria are unacceptable, right, we would proceed with ablation, but we need to have a certain number. Now, for example, this particular ectopics will say ectopic burden is just 1%, ventricular ectopic 354%. So, this patient will not need ablation, but as opposed to somebody who has 20% or VT which is there, then it will be benefited by ablation. So, management of VT, you know that in the acute situation you need a cardioversion, and then assess the risk profile, see whether there are any chances of reversal, whether there are contributory factors, and start on initially on antiarrhythmic medication. And if there is prevention of sudden cardiac death, once everything is excluded, we might proceed to ICD. Now, non-structural heart-related ectopics like RVOT or LVOT can have ablation done as a curative purpose, and in certain good sites we can achieve up to 90% cure rates. Right. Sometimes you need for the rare varieties 3D mapping to get to unusual areas of the heart. So this is an example of that. You have a quick look at sudden cardiac death. When you take the topic itself, sudden cardiac death is mostly due to ventricular arrhythmias, and so 80 to 90% of time, and then about 10 to 20% is due to bradyarrhythmias. Bradyarrhythmias tend to get identified a little earlier, and then they would proceed towards pacing. And this really can be very quick. This is an example of a patient who was wearing a Holter, and within 9 minutes from sinus rhythm had gone into ventricular fibrillation and then asystole and a cardiac arrest. So they look into risk factors of sudden cardiac death. There are certain inherited syndromes and there are certain acquired conditions. And out of the conditions that are common, long QT, Brugada and hypertrophic cardiomyopathy are common inherited conditions that can come into clinical practice. The other ones, ARVCs, catecholaminergic polymorphic VT and short QT syndromes are some of the other areas and other conditions that can lead to this. Acquired syndromes, especially post-myocardial infarction, LV dysfunction and ischemia dilated cardiomyopathy plays a major role. Now, some of the conditions such as Brugada, you can see in the right-sided lead there is a Cope type pattern as well as a saddleback pattern. Both patterns are there in this ECG. This is now commonly recognized. However, sometimes the diagnostic confusion can occur if it happens in a ischemic age group. Long QT syndrome often missed, but if you see a ECG like this, it is of course quite clear. The QTC is measured here. It's more than 544 milliseconds in this particular example. So it's a very clear example of a long QT. A rare short QT syndrome and a bidirectional VT, which is a hallmark of catecholaminergic polymorphic ventricular tachycardia. Tossard could be part of long QT or some other conditions which be related to it. So if any of these conditions are identified and if the sudden cardiac risk is graded to be high, then we would proceed towards an implantable cardioverter defibrillator. And as you are aware, cardioverter defibrillators are devices that has a capacity to deliver a shock and to provide therapy on site so that the sudden cardiac death is prevented. Let's proceed to management of atrial fibrillation. And it's an important area. Although atrial fibrillation per se is a supraventricular tachycardia, as a group, it needs to be handled separately especially because of anticoagulation. And but when you talk about atrial fibrillation, two issues or two particular problems need to be looked into. One is the rhythm itself, whether it is rate or the rhythm. And then second one is, of course, risk of stroke and then prevention of stroke. When you talk about rate and the rhythm control, multiple trials have shown that rate control is not superior to, rhythm control is not superior to rate control. Although as electrophysiologists, we would like to have a good rhythm. But it is probably due to the fact that increased survival, you can convert somebody to sinus rhythm with the aid of antiarrhythmic drugs. So the adverse effects of the antiarrhythmic drugs is counterbalanced by the survival. So it becomes neutral. So that may have been the reason. It has been shown by many trials. But however, rhythm control is preferred in certain individuals, and the rate control, as it is left alone in certain other patients. So, for example, rhythm control is suitable whose atrial fibrillation, if he has a reversible cause, for example, thyrotoxicosis, and if the patient is in heart failure and if the heart failure is making it worse, and new onset atrial flutter leading to atrial fibrillation. So, like for instances like that, rhythm control is superior, and then we should generally work towards rhythm control. And anticoagulation in rhythm control, we can look at it separately, but as a short-term measure, if you are talking about direct current cardioversion, you need to be anticoagulated first and then take the cardioversion subsequently once the anticoagulation is suitably in place. However, in atrial fibrillations which happen suddenly within 48 hours, you will be able to cardiovert. Rate control aims at controlling the ventricular rate when the rhythm is still in atrial fibrillation. Good rate control refers to heart rate of 60 to 80 beats a minute, and in exercise 90 to about 115, and then the patient is generally feeling well. It's not really troubled by the symptoms. AF ablations have come into play over the past 1.5 to 2 decades, and it was initially a treatment of choice or suggested for pulmonary vein triggered AF, which is the majority of the case, and the technique was to isolate the pulmonary vein to reduce the incidence of AF episodes. Two methods have been described, RF ablation earlier and the cryoablation more recently. So, two examples of cryoablation, which is done through a different technique. Cryoballoon is inserted into pulmonary vein, and then circumferential ice ablation is done at a certain temperature, as opposed to drawing lines across the pulmonary valve through radiofrequency ablation. This needs particularly 3D mapping. Now, AF ablations, unlike most of the other ablations, are rather complicated and has a significant complication risk, including stroke, death, and tamponade. Right? So, some patients opt out of it, and also the success rate is at best is about 70% in centers which have done large numbers of cases. So in general, when you select somebody for atrial fibrillation ablations, young individuals with normal LA size and paroxysmal AF are the categories that are in front line for AF ablations. Other decisions are taken regarding other categories according to the individual case. Anticoagulation, I think it's very much more important than the rhythm itself, is to prevent the morbidity and to prevent the embolic strokes. And it's quite clear that anticoagulation drastically reduces the incidence of embolic strokes, therefore morbidity as well as the mortality. And the anticoagulation is judged according to certain criteria, and the Chadbourne criteria is the one which is used, and we are moving away from warfarin to NOACs, and in most of the developed setups, novel oral anticoagulants are available. We also have some access to NOACs, but not very frequently. And so NOACs are very much more convenient in the life point of view in comparison with warfarin. Okay. The way the Chadbourne score is analyzed, there's a certain score which is being given to the conditions, and especially if you look at age more than 75 and previous history of TIA or stroke, it gets a score of 2, and if a female with a score of 3 and a male of score of 2 is generally recommended for anticoagulation unless there is a excessive bleeding risk. So this also needs to be analyzed, and so that's how the decision is taken. And most of the time we are really for anticoagulation, as we know that embolic strokes are really prevented by proper anticoagulation users. The NOACs are becoming very popular, and it's the standard therapy when it is available. So the initial drug which was introduced was dabigatran, and now we have moved to rivaroxaban and apixaban, which are probably better when it comes to bleeding point of view and the management point of view. Very quickly, what we can offer in heart failure. Heart failure is an eternal problem, and then it leads to heart failure as well as arrhythmic deaths somewhere along the line. When the ejection fraction drops to about 35%, patients are generally quite symptomatic. And so there are two categories of patients who are analyzed. One is left bundle branch block patients who need cardiac resynchronization therapy. Other ones are non-left bundle branch block patients. So ones with left bundle branch block, if it's between more than 150 milliseconds or at least 120 and between 150, they can have cardiac resynchronization therapy that can improve their heart failure. Others will be having ICDs. Cardiac resynchronization therapy has actually revolutionized the heart failure. If not for this therapy in a certain segment, patients will have to have a heart transplant. So in the LBB patients, if CRT treatment is done, there is quite a good chance, 3 out of 4 chance of having an improved LV function over a period of time. As you are aware that this needs left ventricular pacing as well, which is done through coronary sinus, and this is X-ray shows a diagram where a thinner lead has gone into a branch in the coronary sinus. Techniques have also advanced over a period of time. Now we have multipolar leads, and there are also active fixation leads which are going into these branches. So these are some of the modern leads as opposed to the older leads. Basically, that is what we can offer, but there are also future trends in electrophysiology, and they are being developed or being used at certain parts of the world. For example, leadless pacemakers, subcutaneous ICDs, remote monitoring facilities so that the patients don't have to visit a center to get their pacemakers and the devices analyzed, more advanced mapping system, and also gene therapy to treat inherited arrhythmias. Few examples of these: leadless pacing, such a small gadget implanted directly into the heart, and at the moment it's going through phases. The present one is a single chamber pacemaker, lasts 6 to 7 years, and I think over a period of time this may become standard. Subcutaneous ICDs done subcutaneously can get explanted at any time, if the treatment changes, only can deliver a shock, cannot deliver overdrive therapy, but again it is becoming popular for conditions like Brugada syndrome. Home monitoring, several gadgets are available, and with a certain frequency the information is being traveled between the center and the patient, so that advice and the therapy can be offered, and if the patient is only seen if it's absolutely necessary. Some advanced mapping systems which are already being used, some non-invasive 3D mapping systems as well. So all these things are areas which are under development. Basically that compromises the talk, and thanks for listening.
Yeah, thank you very much, Asunga, for that very informative overview about what is they are available to a patient now, and also what is in store for the future in the field of cardiac electrophysiology. And I think we will take the questions later end of the session, and we'll move on. So it's once again it's a great pleasure to introduce the next speaker of the day, Dr. Gotabe Ranasinghe. He is the consultant cardiologist at the National Hospital of Sri Lanka, and he is a past president of the then Sri Lanka Heart Association. And being the co-founder of the Sri Lanka Stemi Forum, he has contributed a lot to improve the Stemi care services in Sri Lanka. And introducing the widespread use of tenector plates, and introducing the wagon wheel model, and establishing a STEMI registry in the Western province hospitals. And now we are working together on a very important project to introduce an ECG machine to Suez Harrier ambulance service. I think today he is going to speak to us about antiplatelet in acute coronary syndrome, about the new developments. Over to you, Gotabe.
Good morning. Thanks, Pati, for the kind words. First of all, I must thank College of Cardiology and College of Physicians for inviting me for this lecture. Anyway, so antiplatelet therapy in acute coronary syndrome, newer developments. It's a very complex area, by the way. I try to summarize as much as possible. And so we all know that what I'm going to discuss is actually antiplatelet therapy pharmacology first, and then evidence-based medicine a little bit, and then newer trends in acute coronary syndrome when it comes to dual antiplatelet therapy. So we all know that acute coronary syndrome, we every day encounter this condition, physicians, cardiologists, everyone. And then this is actually it's a myocardial ischemia or infarction. And when it comes to acute coronary syndrome, we describe that. And so also, when we mention acute coronary syndrome, we always talk about a non-ST elevation myocardial infarction, ST elevation myocardial infarction, and unstable angina. When it comes to clinical definition of myocardial infarction, actually that we talk about myocardial injury manifested by or detected by myocardial abnormal cardiac markers like troponins and CPKMB. So that's all about definitions. And so we all know that in the first 30 days of acute coronary event, the benefit of intensive antithrombotic therapy generally outweigh the increased risk of bleeding. So this study, published in 2001, very recent study, you can see that risk is very high in first 30 days. And so bleeding risk is less, but the thrombotic risk is very high. So therefore, giving antithrombotic therapy in first 30 days of acute coronary event is very beneficial. That's very well proven now. And antiplatelets, from medical school days, we studied platelets. And so antiplatelets are all platelet agglutination inhibitors, the class of pharmacological agents that decreases platelet aggregation and inhibit thrombus formation. And these drugs actually continue to evolve as novel agents and increasingly efficacious, and then antiplatelet actions are identified. They're very effective when the newer ones are come into play. And there are different types. We all know that the aspirin, and so aspirin, of course, long-term use, more than 100 is, I believe. And then adenosine diphosphate antagonists, that is, those are clopidogrel, prasugrel, and ticagrelol. Then glycoprotein 2B3 antagonists. And so they are actually apiximab, tirofiban, and FT-fibatide. And so then protease activated inhibitor, they are new one, and they are Varapexer. And so these are the actions of on platelet. I mean, you take the platelet, there are various actions of these various categories of antiplatelet agents. You can see the aspirin, then so ADP receptor inhibitors, and then glycoprotein 2B3 inhibitors. And so this is how it actually affect the platelet inhibition, so by various agents. And so when it comes to dual antiplatelet therapy, that's a cornerstone of cornerstone of management of acute coronary syndrome. And so we always give dual antiplatelet therapy after acute coronary event, even after stenting. So a dual antiplatelet therapy typically involves the use of aspirin and combined with adenosine diphosphate inhibitors such as clopidogrel, prasugrel, or ticagrelor. And there are multiple trials have shown that this combination significantly lowers the risk of the recurrent ischemic events, including stent thrombosis among patients who had acute coronary syndromes. And so you see these KIO trials, it shows actually addition of clopidogrel on top of aspirin after an acute coronary event. And so significantly reduce the cardiovascular mortality. And but there is little increase of minor or major bleeding. And then when it comes to this study, the Triton Timid 38, they compared prasugrel and the clopidogrel. Then that study showed actually in combination, when it comes to dual antiplatelet therapy, prasugrel is better than clopidogrel. So that's we are in patients with acute coronary syndrome even after stenting. And then Plato compared actually ticagrelor versus clopidogrel and in acute coronary syndrome, and it showed very clearly that the ticagrelor is better than clopidogrel. So, there was a minor the increase of major bleeding in patients who took ticagrelor. Then there was this ticagrelor or prasugrel in patient with acute coronary syndrome. So this is ICER React 5 study. Actually, that showed the patient who took prasugrel was associated with 2.4 reduction of primary outcome, death, myocardial infarction, even stroke, and compared with patients who took ticagrelor. And but stent thrombosis was rare in both groups, but compared to bleeding, major bleeding rates were similar in both groups. So in this is the study which showed actually prasugrel is better than ticagrelor. And how did all these studies, findings apply to ESC guidelines? So although the clopidogrel remains the most commonly used P2Y12 inhibitor, the guidelines, now newer guidelines favor the more potent, the newer generations P2Y12 inhibitors such as ticagrelor and prasugrel. And the 2020 ESC treatment guidelines for non-STEMI acute coronary syndrome preferentially recommend ticagrelor or prasugrel as a standard treatment for all patients presenting with acute coronary syndrome and with class 1 recommendation. And these agents should be used unless there are contraindications. And so what about duration of this antiplatelet therapy? So we start with aspirin and clopidogrel or prasugrel or ticagrelor. What's the duration? The recommended duration of dual antiplatelet therapy in acute coronary syndrome and PCI even after acute event is moving target, is changing. But for most patients, DAPT is recommended for minimum 12 months after an acute coronary event, whether the patient had PCI or not, so 12 months. A daily aspirin dose of 75 to 100 milligram is recommended in ESC guidelines, and adequate dose of aspirin for long-term therapy for all these patients is currently being studied. So whether it's like, what's the dose for long-term, more than 1 year. So there is a trial going on at the moment, it's called adaptable study. So this is a study for whether to continue 12 months or more dual antiplatelet therapy. So this is called DAPT study. So this about 10,000 patients who completed 1 year of DAPT, aspirin and plus clopidogrel or prasugrel, assigned to prolong DAPT, and then found out the events, and then after PCI with DES. And so they continued dual antiplatelet therapy for about 30 months, and they found that reduced the rate of stent thrombosis, death, MI, and stroke, but with the cost of increased bleeding in these patients. Then this Pegasus study, and also this is study long-term use of ticagrelor in patients with prior myocardial infarction. And so again, this study, of course, 21,000 patients showed that continuation of ticagrelor with aspirin for more than 12 months after acute event and reduced MACE, but again with the risk of bleeding, especially with 90 milligram twice a day compared with 60 milligram twice a day. So there is a tendency now after 12 months, and so one may, especially when the ischemic event rate is high, so one may start 60 milligram twice a day with aspirin than 90 milligram twice a day. So what are the new developments in this area? So ticagrelor with or without aspirin, high-risk patients. And so this is new study, 2019 is Twilight study, total about 7,000 patients, randomized to 2 groups, and given ticagrelor plus aspirin, and then ticagrelor plus placebo. So at 1 year, the rate of clinically significant bleeding was lower in ischemic events, and in the patient with ticagrelor monotherapy compared with ticagrelor and aspirin. So you can continue aspirin, you can continue ticagrelor more than 1 year, and bleeding rates will be lesser with when you compare with aspirin. And remember that the Stemi patients were not included in this study. So this is all non-Stemi patients. So therefore, this concept of early de-escalation of dual antiplatelet therapy is a new area of investigation. Most of the currently available data support that view that early intensive DAPT can be safely de-escalated over time with aspirin withdrawn and continuation of P2Y12 inhibitor, and with proper ischemic protection while reducing the risk of bleeding. So latest recommendation in Stemi and ESC guidelines, and for Stemi as well as non-Stemi. And so when it comes to non-Stemi, actually same thing apply for Stemi as well. You can see, and these patients depend on the ischemic risk as well as the bleeding risk. If you take the low bleeding risk patients, you can start aspirin or prasugrel, aspirin or ticagrelor, or aspirin or clopidogrel for 12 months. And then after that, you can continue if you want, and especially ischemic risk is more, and aspirin or ticagrelor, aspirin or prasugrel, aspirin or clopidogrel. And there's a newer study called Pioneer study. They showed even you can continue if the ischemic risk is more, aspirin plus rivaroxaban. That's a new study. And there's the de-escalation is possible in 3 months. You can see in low bleeding risk patients, so aspirin and ticagrelor for 3 months. After that, you can stop the aspirin and then continue with ticagrelor. But the bleeding, when the bleeding risk is high, you can see that aspirin or clopidogrel, and very high bleeding risk, of course, you give 1 month. After that, you continue with the clopidogrel. If the bleeding risk is moderate or high, so you can continue aspirin and clopidogrel for about 3 months, and then you can continue after that with aspirin. So this is how it happens in 2020 guidelines. And so what about pre-treatment with P2Y12 inhibitor in Stemi patients? Routine pre-treatment with P2Y12 receptor inhibitor in non-Stemi patient is not recommended. And because P2Y12 inhibitor pre-treatment was not associated with improved clinical outcome, but instead there was significantly increased risk of bleeding events according to ASCOT trial, SCAR trial, and various other registries. So they may increase bleeding risk, and or even sometimes delay the procedure in patients scheduled for CABG after diagnostic angiography. So you give pre-treatment the loading doses for STEMI but not for non-STEMI. And so what about the recommendation for STEMI? And so you can see that antiplatelet therapy, low dose aspirin is given to 75 to 100 long term. So DAPT is usually for 12 months. And so if you want, you can continue with ticagrelor especially for more than 12 months, up to 30 months you can do. And so PPI, proton pump inhibitor, always recommended with the dual antiplatelet therapy. And so that is very important. And sometime in patient with atrial fibrillation, LV thrombi, you always can combine with triple therapy, so addition of anticoagulant agent, which I'm going to discuss a little later. And so all STEMI patient with stent implantation, addition of oral anticoagulation, triple therapy should be considered only for first 6 months because of bleeding risk. And also, I must tell you that use of ticagrelor and prasugrel is not recommended as a part of triple antithrombotic therapy with aspirin with oral anticoagulation. It has to be always clopidogrel because of the bleeding risk. So switching from one P2 Y12 inhibitor to another one, that is called de-escalation. And so it can happen from more potent P2 Y12 inhibitor such as prasugrel or ticagrelor to clopidogrel, and in certain circumstances such as high risk bleeding or need for oral anticoagulation. These situations we always do. So de-escalation should be avoided in first 32 days after an acute coronary syndrome or PCI because of high risk of thrombotic event. And so you can see this is a little complicated, but you can see that de-escalation possible from clopidogrel to ticagrelor, clopidogrel to prasugrel, prasugrel to all the ways. But make sure that always from clopidogrel to ticagrelor and always in acute setting, you give a load-in dose, and you have to wait the 24 hours and from the first ticagrelor dose. So each way is possible, but make sure that you give a loading dose. And also in certain situations, you have to wait for 24 hours, especially when it comes to from changing from prasugrel to clopidogrel or ticagrelor to clopidogrel. And not only acute situation, even chronic setting, if somebody is on, suppose maybe the clopidogrel, if you want to change it to ticagrelor, of course, you can change, but make sure that from clopidogrel to ticagrelor, so you have to wait for, you have to give the load-in dose, and so also from ticagrelor to prasugrel, and so you have to give the load-in dose. And so then wait for 24 hours. You can't do it immediately. So what about concomitant use of antiplatelet with anticoagulation? Current clinical practice guidelines recommend combination of DAPT and anticoagulant therapy for hospitalized patients with acute coronary syndrome, irrespective of whether invasive or conservative strategies are planned. So usually we give preferential anticoagulants are enoxaparin, all the acute coronary patients. But even sometimes, even when they are going for intervention, you can give bivalirudin and fondaparinux or unfractionated heparin are the class 1 recommendation during initial period, up to even 48 hours of the event or until PCI is planned. So you can give all these agents. And approximately, we all know that 5 to 10% of atrial fibrillation patients are referred for PCI. And similarly, atrial fibrillation develops in up to about 20 patients with acute coronary syndrome patients. So these patients may need to be started on dual antiplatelet therapy with oral anticoagulation. It's a bit of a dilemma. So addition of dual antiplatelet therapy to oral anticoagulant therapy results in at least 2 or 3-fold increased bleeding. This is the biggest problem, but still you have to do. So it's a challenging clinical scenario which needed to be assessed very, very carefully. So this is a study which showed the use of clopidogrel with or without aspirin in taking the patients taking anticoagulant therapy undergoing percutaneous coronary intervention. This study showed patients who had clopidogrel and including giving those patients aspirin increase the risk of bleeding. So if somebody is on clopidogrel, adding anticoagulant agent, warfarin is much better than giving all three agents together. So this is Augustus trial. So this is a study, very important study. Patient who had acute coronary syndrome and they had atrial fibrillation. So they were divided into two groups. One group, they all on clopidogrel, and one group took apixaban and then aspirin and placebo. Other group took clopidogrel and aspirin and warfarin. So they checked the primary endpoints, and then it showed actually. Now you can see that patients who took apixaban, it was associated with 4.2% absolute reduction of major or clinical relevant the endpoints and bleeding complications. So here, what I'm going to highlight is patients who took apixaban and placebo, they did better than patients who took warfarin and aspirin, patients who took the clopidogrel or any other the antiplatelet agent. So they did very much better when you come. The apixaban group did very much better than any other group. So what I'm trying to highlight is the thrombotic events were similar across the individual randomized to anticoagulation with apixaban and warfarin and aspirin and placebo. So giving aspirin to all these patients who are on dual antiplatelet therapy, there is a risk of bleeding. So patient with acute coronary syndrome and atrial fibrillation, the totality of evidence favors short duration of triple therapy in most cases, and then dual antiplatelet therapy with P2Y12 inhibitor, clopidogrel, preferably. And so then you can add novel oral anticoagulant agent at least for 12 months. So you can see very clearly here, after an acute coronary event, you can see if they had PCI or not, you can give P2Y12 inhibitor up to about 12 months. Then you can continue novel, especially novel agents, anticoagulant agents, more than long-term use. And aspirin always you can use after 1 month. And so even the way they are medical treated or the PCI is the same. So however, many patients in clinical practice, in day-to-day practice, do not perfectly meet trial inclusion criteria and have demographic or clinical or other characteristics that require special consideration. We see all these patients, but they come with different backgrounds, different clinical problems, different comorbid conditions. It's a challenge. So ultimately, final decision actually depends on the clinician's assessment of the thrombotic as well as the bleeding risk. If the bleeding risk is more, then you have to curtail the agents. And if thrombotic risk is, of course, more, then you have to increase the number of agents. So that's how it works. And in summary, the guidelines regarding the use of antiplatelet therapy in acute coronary syndrome is subjected to continuous changes. And loads of trials are continuing, and so there is a continuous change. The most patient, DAPT is recommended, that is dual antiplatelet therapy is recommended for at least minimum 12 months after an acute coronary syndrome. But depending on the bleeding as well as thrombotic risk, your duration of therapy can vary as I highlighted. Early de-escalation of dual antiplatelet therapy after 3 months is supported by Twilight study. That's the latest study. If you want, you can actually de-escalate triple therapy or dual therapy and after 3 months. And in patients who need triple therapy, stopping aspirin early is supported by, as I mentioned, Augustus study, maybe even 3 months, maybe even 1 month, depending on the thrombotic risk. Thank you.
Thank you, Gotabaya, for a very comprehensive account on the evolving evidence about the use of antiplatelet drugs in acute coronary syndrome. I think you have driven the message that even though evidence is summarized in guidelines, it is always clinicians to decide in individual case in regarding decision evaluating the ischemic and bleeding risk in a patient. I think we'll take the questions at the end of the sessions and move on with the next speaker. So next speaker is Dr. Sampath Vitanamasam. He is the resident cardiologist at the National Hospital of Sri Lanka, and he's a past secretary of SLHA and for successive years. And he started his career as a cardiologist at the District General Hospital, Chilau, and he developed a unit there, cardiac unit, and also was instrumental in establishing a cardiac unit at Base Hospital Avisavela, where he was covering up duties. Today he is going to talk to us about a very common topic, very relevant topic to all of us, a practical approach to the management of systemic hypertension. Over to you, Sampath.
Thank you very much for that kind words. First of all, I should thank Ceylon College of Physicians and the College of Cardiology for giving me this very valuable opportunity. Good morning, virtual audience. Good morning, chairpersons. And my topic today, practical approach to manage hypertension. Is hypertension known to be a ticking bomb, the leading cause of morbidity and mortality worldwide, even though it takes very simply by most of us, even the doctors, is the one of the main cause or the major cause of ischemic heart disease, a stroke, especially the hemorrhagic stroke, and then again the ischemic strokes also, and a major cause of heart failure, atrial fibrillation, and also peripheral vascular disease. And again, one of the major cause of chronic kidney disease, and major cause of blindness. And not only that, it can cause cognitive decline and dementia. And along with all these, and is one of the major cause of mortality worldwide. So even though we took it very simply, and this is one of the major cause that world population dying daily. So 1/3 of the world is affected. No difference in our area, Southeast area, and no difference in Sri Lanka. Somewhere around 30% of the people are affected. Unfortunately, most of them are not even aware that they are hypertensive. And this talk, I'm going to make it very simple and pass simple messages to the audience. And I try to summarize around with simple questions. The essence of hypertension that most of the guidelines concentrated on. What is the blood pressure value to diagnose high blood pressure? When to start antihypertensive drugs? Which drug regimen to choose for particular patient? And what is the blood pressure target that you need to achieve? And then when to suspect secondary cause and to do any referrals to relevant field. So those are the questions that I wanted to highlight in my lecture. And if you know this bit, I think probably we can manage our patients quite efficiently and safely. So before getting to the hypertension cutoff value, the better to know about what is hypertension, especially the definition. The hypertension defined as the point at which the benefit of treatment of elevated blood pressure outweigh the risk, and of course the cost also a main concern. Now, when accumulating data and when trial evidence coming out, this point varies side to side and also area to area. The good example is, you already know, the ESC guideline hypertension definition is slightly differ from AHA guideline because they consider the difference of same set of data but analyze it indifferently, and there are cost beneficial issues they analyze differently and come out with slightly different values. And this could even may be different in future. But at the moment, for this lecture, I'm going to concentrate on ESC guidelines because I don't want to make you confused. The hypertension, when you are talking about hypertension, even in Sri Lanka, the most popular way of office blood pressure measurement. So if you take office blood pressure measurement, which is much more popular, the hypertension is defined as systolic blood pressure value more than 140 mercury millimeters and the diastolic blood pressure more than 90 mercury millimeters. This is for office blood pressure measurement. But having said that, I should tell most of us not measuring blood pressure properly, and improper blood pressure measurement indefinitely causes errors, because if you want to check the blood pressure, that you know the proper technique, and you have to have at least 5 minutes in a quiet area and at least 2-3 readings at the same time to get the proper reading. So which is less practical in our setup, but at least once in a year we need to stick to these rules to give the best for our patients. And now more and more evidence coming out, the out-of-office blood pressure measurements are better and more reliable in terms of outcome and also with the complications of the patients. So home blood pressure measurements and the ambulatory blood pressure measurements are now essential part of blood pressure measurement, especially in some cases. Home blood pressures and the ambulatory blood pressures are essentially lower than the office blood pressure measurements. The definition, according to the ESC, the home blood pressure measurement more than 135 systole and more than 85 diastole considered as hypertensive. And in case of ambulatory blood pressure measurement, the daytime average more than 135 in systole and more than 85, the same as home blood pressure, considered as hypertensive. Night average is more than 120 systolic and more than 70 diastole, and 24-hour average more than 130 systole and more than 80 diastole taken as the hypertensive cutoff. So these are the cutoffs, but more importantly, we have to taken into patients' requirements sometimes, and which will come later. And this classification, again slightly different from AHA and ESC, but I'm not talking about ASC guidelines here. So the hypertension categorized to grade 1 hypertension, grade 2 hypertension, grade 3 hypertension, and this is important for us to treat our patient, which strategy that we select for individual patient. So grade 1 hypertension, simply 140 to 160 systole and 90 to 100 diastole. Grade 2, 160 to 180 systole, 100 to 110 diastole. Grade 3, more than 180 systole, more than 110 diastole. Not only that, the normal blood pressures also they divided into 3 parts: optimal, normal, and high normal, which again has some implication when you are treating your patient. Blood pressure phenotypes. Mainly we are concentrating sustained hypertension. So when we get office blood pressure, if the blood pressure is high, that is the cutoff 140/90, we consider them hypertensive. If it is lower than that, we consider them normotensive. So that is what we usually see, but we have to keep in mind there are some other phenotypes of hypertension that we can miss with office blood pressure measurement, especially white coat hypertension, where we tend to overtreat the patient, and masked hypertension, where we tend to undertreat hypertensive patient. Both has some implication. White coat hypertension has its own problems, but more than that, masked hypertension is a problem because its prognosis and the complication may be worse than the sustained hypertension. So that's important for you to identify these patients before they develop complications, and especially for you to identify white coat hypertension and masked hypertension, you have to go for out-of-office blood pressure measurements. So that's why these out-of-office blood pressure measurements are coming into picture and has more implications in patient management more and more. Then the second question, when to start antihypertensive drugs? This is again, you can again depend on the patient, but to make it much more simplified, if you are in, if your patient's blood pressure grade 3 or grade 2, that is simply more than 160 upon 100 mercury millimeters, or with grade 1 hypertension, that is 140 to 90 mercury millimeters, with high cardiovascular risk. High cardiovascular risk is defined by established cardiovascular disease, diabetes, CKD stage 3 or more, and more than 10% annual risk, 10-year risk of cardiovascular event, or developed, already developed hypertension mediated organ damage. If your patient in one of these three categories, it's better to start treatment immediately because that is beneficial and they need treatment. If not, if the patient is in grade 1, that is 140 above 90 mercury millimeters, without having previously said high risk factors, we can try lifestyle changes for 3 to 6 months for this patient and see how it responds. Usually they respond, and you can delay hypertensive treatment even though this patient needs regular blood pressure measurement in future. But if it is not successful, then you can treat them as hypertensive patients. And the high normal category, this is not in the hypertensive category, high normal category, that is systolic blood pressure more than 135 upon 80, but less than 140/90, with established cardiovascular disease. And these patients come into high risk group, and these patients again you can consider treating for hypertension, and it gives long-term beneficial outcome. And which drug regime to choose? And couple of things that we have to keep in mind, that all of you are very much aware, but for sake of completeness, I will just go through this list. First line and second line drugs, what you can use as the first choice, and which drug for whom, whether there are any particular situations, some drugs are particularly beneficial, and whether we use monotherapy with high doses or multiple drugs, and which combination correct, and what is the timing optimal for patient, and what are the failures, and how can solve these problems. And these are the few things that I thought of which are important practically for us to treat patient with hypertension. First line drugs, you all are very much aware, thiazide or thiazide-like drugs, AC inhibitors or ARB blockers, and calcium channel blockers. So these are the first line drug, and whatever the guideline we talk about within previous decade or so, these are the first line drugs to choose for your patient. And the second line drugs, and that of course you can select according to the patient's clinical condition depending on the situation. Mineralocorticoid receptor antagonist, that is spironolactone, especially for hyperaldosteronism patients, is very much beneficial, and of course it's first line in that situation. And then beta blockers, when the patient is having background coronary artery disease or heart failure. Alpha blockers, especially all of you are aware, for prostatic hyperplasia and urinary obstructive symptoms. Centrally acting drugs, especially for pregnancy or very resistant type of hypertension when the other drugs are failing. Vasodilatation, like hydralazine, is especially useful sometimes in heart failure patients in combination, and then again pregnancy and when the resistant patients are encountered. And initiating drug therapy, if your patient is in the initial stage of hypertension, that is stage 1 hypertension, it's likely that your patient is responded to single agent. So in case you can start single agent. In younger patient, AC inhibitors and ARB are the choice of drug, and then older patient, calcium channel blockers are the better first line drugs. In a diabetic patient, AC inhibitors in all ages are beneficial over the other two agents. So this is rough guide for you to start or select your single the antihypertensive agent. But when it is much severe hypertension, especially more than grade 2, the single agent unlikely to be responded. So the recommendation is to start with 2 drugs at the beginning rather than starting with 1 drug and going for maximum dose and the add-on the second dose, which were taught in our medical school time couple of decade ago. Now you can start with the combination pills which are available in the market, or you can simply use 2 tablets, even though it's a bit inconvenient. And the recommendation is start with a lower dose and titrate up until the patient get the proper control. And the drug therapy should be tailored to the patient need. And again, you should keep in mind that the patient has right even to refuse your treatment even though they are in hypertension. Long-acting drugs exhibiting less blood pressure variation. Say, for example, with longest biological half-lives, drugs like perindopril, telmisartan, amlodipine, bisoprolol, nebivolol, and clothalidone will give a smoother effect and less side effects. And definitely, in our setup, it should be affordable. We have quite a lot of experience that we are prescribing sometimes without knowledge the cost of the drug and very expensive tablets, and the patient is not taking the tablet. And it should be well tolerated without significant side effects. So when you are prescribing, these are the things to keep in mind. And pill combination often need more than 1 drug. That is for polypharmacy to get the optimum control. And increasing numbers of drugs contributes to non-adherence called pharmaceutical burden. Preferred 2-drug combination include RAS blockers and CCB or diuretic. Combination of long-acting drugs such as telmisartan amlodipine combination has the best smoothest index, buffers excessive blood pressure fluctuation over 24-hour period. So less side effects drugs are better than drugs with side effects with less blood pressure control over 24 hours. Better not to combine AC inhibitors and ARBs because of potential lethal complications. And these are few drugs that I wanted to highlight that we are commonly used in our practice with some overall beneficial effects. Calcium channel blockers, ARBs, AC inhibitors, diuretics, and beta blockers. The things to consider, how smooth the effect over 24 hours. Almost all the drugs has some drugs has especially slow releasing agent gives a good 24-hour control. The less early morning BP surge is again one thing to think about, and some drugs are good at of it, especially diuretics are not good at giving a protection on early morning surge. And blood pressure lowering at night, especially beta blockers are not good at that, and the rest of the other drugs are good at giving lower nocturnal blood pressure response. Less blood pressure variation. Most of the drugs are good at, but AC inhibitors and beta blockers are not good at and that response. Drugs example, you are all very much familiar with the drugs that we have, so I'm not going to take your time on it. And the timing. When you are timing the tablet, is rather than just keep it in mane, nocte, or twice daily, it's better to tell the patient to exact timing and the implication of it. Sometimes, depending on now that the practical reasons, patient's occupation might need to consider sometimes. Sometimes the other person who gives drugs, the practical things has to be considered. But if you, the other one most important thing that you to consider is early morning blood pressure surge. For you to prevent early morning blood pressure surge, it's better if you are giving a single pill. To give it is early morning on the when the patient wake up as the first thing, like that you are taking thyroxine, or otherwise at the late evening. Or if you are taking two drugs, you can separate one in the morning and one in the evening, which gives the patient a smoother blood pressure control over 24 hours. Rather than now, most of the patients, now we unfortunately, unless you are doing a blood pressure 24-hour ambulatory monitoring, we don't know how the blood pressure control over 24 hours. And some patients, we know that when they come to the office, their blood pressure may be normal, but may not be the same at home. And non-adherence is a very common problem. Actually, this is the most common problem that we don't get the proper blood pressure control. Up to 50% of the patients are non-adherent, and 20% patients are never taking antihypertensive drugs even though we prescribe. The main problem is, like diabetes in the initial stage, hypertension, unless it develops its own complication, is an asymptomatic disease. And these drugs that we are giving has potential side effects. So most of the patients, especially young people, think, why I bother to take this tablet and giving troublesome side effects, especially if you with some drugs, something like impotence or lethargy and sometimes dizziness, why I am bothering to take these drugs. So as a physician, we have to detect it, and we have to motivate the patient and actively engage in the patient management rather than just prescribing and adding one another other whenever they comes and we see the blood pressure, because sometimes maybe the reason simply non-adherence or some other reason. Lifestyle changes do matter. Actually, whatever the drug that you prescribe, this is potentially beneficial. The weight loss, diet pattern, low sodium, physical activity, and alcohol moderation can give rise to significant reduction of blood pressure along with your tablets. So we have to advise all our patients to adhere to these things. Sometimes one patient may think that it cumbersome, but definitely is valuable not only in hypertension management, the other possible coexisting problems, ischemic heart disease, diabetes, whatever the other problems, this is very much beneficial. Then, next question, what is the blood pressure target to achieve? First goal, achieve the target of 140 upon 90 mercury millimeters in all patients. So that is the primary target, like our primary cholesterol targets. LDL targets. So achieve that for all the patients. That is our primary target. Once you achieve that, then slowly try to achieve to 130 upon 80 for most of the patients. Having said that, I just want to tell you that most of the patients, now it's what is the normal is above the 115 to 75. Above that, we tend to develop side effects. Even though we say our normal blood pressure 120/80, so it's now 115 upon 75. So then better to get into slightly lower, and our secondary target is 130/80. Once you achieve that, if your patient is more younger is fortunately less than 65 years, and to achieve the target, try to achieve the systolic target 120 to 129. And for if it is older patient above the 65 years, you can keep at the same level 130 to 140. And the diastolic blood pressure, irrespective of your age, try to achieve to between 70 and 79, but not less than 70. It increases the complications and side effects. This is the same slide again in a different way, but is more clear. between 18 to 65, the systolic target achieve 120 to 129. Elderly people, more than 65 years, your systolic target is ultimate systolic target is 130 to 140. Diastolic blood pressure for all ultimate target is 70 to 80. So this is what you need to achieve. Think about ourselves. How many percentage of our patients have achieved this target? Probably in my case is probably less than 20%. It's so much difficult to achieve this real target. Goal is a range than a single value, that is obvious. The most importantly that we don't want to jump and get the blood pressure control in 1 week's time or 2 weeks' time. We can achieve it gradually, step by step, but most importantly, we have to maintain it persistently, which is much more difficult than actually achieving. My final question, and when to suspect secondary cause. And this is again important, the main reason, because most of these causes are curable, the secondary cause. If you identify, at least if you can cure a patient with hypertension, that may be a big relief for the patient. So better suspect whenever is need to be. These are the group that you need to suspect secondary causes. Younger patient, that is less than 40 years with grade 2 hypertension, onset of any grade of hypertension in childhood, acute worsening of previously stable hypertension, especially in elderly patient, and resistant hypertension, grade 3 hypertension or hypertensive emergency, presence of extensive end-organ damage, clinical or biochemical features suggestive of endocrine causes, hypertension or CKD, clinical features suggestive of obstructive sleep apnea, which is a hidden cause of hypertension, symptoms suggestive of pheochromocytoma or familial history of pheochromocytoma, and also, just as a habit, look at prescription. There may be some drugs obstructing your antihypertensives, not allowing to work. When to suspect secondary cause, these are the clinical features to think about or try to find out. Increased serum creatinine concentration, moderate to severe hypertension, and unilateral small kidney and renal bruit. All of you are aware this is suggestive of renal artery stenosis and may be curable in certain set of patients. Some other patients, the antihypertensives are equally good. Elevated serum creatinine and proteinuria is a hallmarker of kidney disease. And hypokalemia is one of the easy way or initial suspicion point to identify primary hyperaldosteronism. And apneic episode snoring for obstructive sleep apnea. And you all are very well aware of symptoms of pheochromocytoma. Better to ask in history, especially if the patients are complaining of headache. Sometimes you mess up why this headache comes up with the hypertension itself or flushing. But most of our patients, I have seen that they are complaining of headache with blood pressure with 160/70, which is less likely because usually hypertension with headache associated with hypertension emergency in a severe sort of hypertension for majority of the cases. Then the murmur or brachioradial radiofemoral blood pressure difference in coarctation of aorta, and the symptoms of Cushing syndrome and thyroid syndromes. Better to look into neck of a patient which is in front of you. So that might give quite a lot of clues for your patient's underlying clinical problems. And as I said, don't forget drugs, because some drugs in the prescription without knowing that can inhibit your antihypertensive drugs action. And age and secondary cause, there is a link, and you can suspect depending on the age group what secondary cause will be there. Say for example, most of the children, the cause is either renal disease or a coarctation of aorta, and most of the young adults, causes thyroid dysfunction, fibromuscular dysplasia, especially in females, and renal parenchymal disease. And in adults, usually the causes are hyperaldosteronism, probably is one of the most common thing, because even without proper investigation, sometimes our patients are very well respond to adding spironolactone, probably is due to underlying hyperaldosteronism. Unfortunately, we don't have much of the facilities for do all the investigations, especially renin angiotensin ratio for these patients to diagnose. Thyroid dysfunction, obstructive sleep apnea, Cushing syndrome, and pheochromocytoma. So this is a rough guideline that I, based on the ESC guidelines, I talk about the practical problems that we encountered and try to give you a shortened forms of answer for you to keep in mind. Hypertension is very common, simple, but when it comes to the treatment and outcome is not easy. I conclude my talk here. Thank you very much.
Thank you, Sampath, for that very comprehensive, very important talk on the very practical approach to a patient with systemic hypertension. Thank you very much.
Thank you.
So we'll move on to the last item, the next speaker is Dr. Roshan Paranaman. He is a consultant cardiologist at Base Hospital, Chilau, and he is also the current treasurer of the Sri Lanka College of Cardiology. And before moving to his current station, he worked at Base Hospital Polonnaruwa and also Provincial Hospital Anuradhapura. And in both places, he contributed a lot to establish cardiac catheterization labs. And even at present, I know that he is working hard to establish a unit, cardiac unit at Chilau. And he will be talking to us today on the physician's role in cardiac risk assessment in non-cardiac surgeries. Over to you, Roshan.
Thank you very much, sir, for the kind words of introduction. And also, I would like to thank Ceylon College of Physicians and as well as College of Cardiology for giving me this opportunity to talk on, I would say it's really talk area or as well as gray area in practice, especially physician's practice as well as cardiologist practice. So when I was actually asked to prepare a presentation on this, I was doing my echo clinic. So in our practice, we get around 20 to 30% of patients are from surgeons as well as gynecologists as well as obstetricians, and their main worry is the preoperative cardiac risk assessment. So most of the patients we get into the echo room while they are on the way to the theater. So that is actually this very difficult scenario, because most of the patients are fasting. They are coming at the late in the morning session for a in-ward echo, and they are straight away waiting to go to the theater. And we all are pressurized because we had to take a correct decision, and we had to take the correct decision as well as the time of surgery. In case if we postpone the case, then patients will be upset. And this one case actually I got during that my session. He's 65-year-old male, diagnosed hypertensive diabetes, and as well as he on insulin. And he underwent percutaneous coronary intervention to left anterior descending artery with drug-eluting stents 10 months back due to limiting angina. He was on dual antiplatelet treatment, and he was awaiting TURP on the same day. And the second patient, 69-year-old, hypertensive and diabetes for 10 years, and he was a smoker as well. And he was awaiting total hip replacement due to severe bilateral osteoarthritis of knee joints, where he can't walk at least 10 meters. And third case, 64-year-old male, diabetes for 15 years, hypertension, hyperlipidemia. He was treated on the same hospital admission for non-STEMI. And he was found to have ECG changes, as well as he had an echo a few days ago and showing the EF of 40%. And he was awaiting wound toilet, as well as maybe they want to proceed with lower limb amputation because it was horrible wound. So your day-to-day practice and referrals, even though being a physician, you get a lot of referrals from your surgical colleagues. When you work in a peripheral hospital like base hospital, you have to deal with all your surgical referrals because there's no cardiologist. And what do? Do you guess? Do you argue with your colleague or postpone surgery? Or you have to evaluate and re-stratify and manage those patients. And sometimes you have to refer for cardiologist as well as for invasive test, depending on the clinical scenarios. So to do that, you have your expertise because you may be practicing as clinician for years and years. So you have your practice experience, as well as you have some evidence-based medicine. And sometimes you have research evidence, as well as you have guidance from from Sri Lankan guidelines, but you can use American Heart Association guidelines as well as ESC guidelines. So, my dear colleagues, I'm going to talk to you on next 15 minutes how to approach these patients who is supposed to have cardiac problems and they are waiting for non-cardiac surgeries. So, when you get a patient, you have to do a risk stratification. So you have to go through the history, examination, as well as some investigations. And then you have to assess the severity of the underlying cardiac problem. Then only you can do the risk stratifications. And as well as you have to do the modification of level of care interventions depending on the patient's condition. And as well as you have to discuss the standard recommendation before they are subjected to the anesthesia. So when you get a patients with cardiac patients or even non-cardiac patients, so why do they have high risk during this perioperative period? So because as you know, especially with major surgeries where there is large fluid shifts occur, like blood volume loss or maybe sometimes long duration of surgery. So that matters major hemodynamic stress in the patient. So that could be due to changes in cholinergic or catecholamine release, as well as body temperature also fluctuates. As a result, the risk also fluctuates. And sometimes during anesthesia, the pulmonary functions also alterates. And also, as you know, there's increased coronary thrombogenicity because most of the time we have prothrombotic and fibrinolysis balance. So as a result of surgery, sometimes you get fluid, the vascular damage as well as the tissue fluid leak results in more prothrombotic factors, result in more coronary thrombosis. Not only the last I mentioned pain also matters, especially patients are undergoing regional anesthesia, they get pain, they are more sensitive. So as a result of pain, they are this cholinergic, the catecholamine release results in tachycardia as well as some malignant arrhythmia. So all contribute. A type of anesthesia also matter because sometimes they do under general anesthesia, sometimes regional anesthesia like spinal or control epidural, as well as some local events. So what happens during anesthesia? There's a decreased systemic vascular resistance. So as a result, the blood pressure tend to drop. Sometimes as a result of surgery, the stroke volume is low because because of the fluid leakage, intravascular compartment loss, and as well as sometimes general anesthesia lowers systemic blood pressures. Sometimes it up to 30%, and intubation process itself increase blood pressure maybe up to 20 to 30 millimeter of mercury. Some anesthetic agents lower cardiac output by 15 to 20%. So when you get patients, so you have to decide whether you are going to give your opinion, or you are going to stratify, or you are going to do alteration in the management. So it is necessary to follow this simple stepwise manner to prevent complications. As well as I told you earlier, there's a gray area, so you can actually practice without any problems if you follow these stepwise guidelines, which was adapted from the ESC as well as the American Heart Association. So you have to decide once you see a patient, whether you have to decide whether that patient is awaiting urgent, emergency surgery or elective surgery. And you have to assess the clinical risk predictors, whether they have major, intermediate or minor clinical risk predictors. As well as when you see a patient, you have to assess the functional capacity, the exercise tolerance. And not only that, you have to assess the surgical risk factors. Even though you are not a surgeon, but you should know what surgery or which surgery belongs to the high risk, intermediate or low risk category. And also you have to look for the recent coronary event or revascularization. So when we talk about the major clinical risk factors, so if you see a patient during recent unstable coronary syndrome like recent MI or even acute MI, unstable angina and Stemi, so they belong to high risk categories. Patient with decompensated heart failure are also high clinical risk. And there may be significant arrhythmias, we call this malignant arrhythmias, like high-grade AV blocks, symptomatic ventricular arrhythmias, as well as supraventricular arrhythmias with uncontrolled ventricular rate also belong to major risk categories. Sometimes when you see patients with valve disease, especially this our part of the world, we see a lot of patients with chronic rheumatic valvulitis. They come with severe mitral stenosis as well as mitral regurgitations and also aortic valve disease. So those are the major clinical risk factors. And you should know the intermediate clinical risk factors. Intermediate clinical factors are mild angina. It may be class 1 to 2 angina, past MI who may not have angina now, and patient with compensated heart failure or the patient with past heart failure, they are well now. And also patient with diabetes, especially patient with diabetes who are on insulin and also with their target organ damage. And patient with renal insufficiency, the creatinine level more than 2 milligram deciliter is considered to be intermediate clinical risk factor. And the patient with minor risk factor, you have to look for them advanced age. There may be some ECG changes like LVH, LBBB, and etc. And sometimes they have rhythm abnormalities other than sinus. The patient may be having atrial fibrillation. And sometimes the patient with lower functional capacities and they can't even walk on level ground. And the patient with past CVAs and also patient with uncontrolled hypertension during the same hospital admission is considered to be minor clinical risk predictors. So when you see a patient, you have to assess their exercise tolerance. And exercise tolerance, we usually go by the METs, metabolic equivalence at rest is considered to be 1. So when a patient does activity, so then their metabolic rate goes up, MET goes up. So depending on their METs, so we can consider them into poor, moderate to high, good exercise tolerance as well as excellent exercise tolerance depending on their level of activities. So this is rough guide because when you see a patient, you don't have time to assess their proper exercise tolerance. You can't put them onto the treadmill. But if you go through simple like assessment, if they can even do light housework or if they can walk on the ground for 50-60 meters without any problem, then we know that here the patient has exercise tolerance around 3 METs. If they can take or they can walk up the flight of stairs without any problem, so they have approximately 4 minutes. So 4 to 10 is moderate sports, moderate exercise capacity, so they can engage in exercise. So that is moderate exercise. So if they can engage in strenuous sports or exercise, then they have very good exercise tolerance. So that is actually important to re-stratify those patients. And even though I told you are not a surgeon or you are not a gynecologist, but you should know the risk, level of risk depending on the surgery. The low risk surgeries, actually the low risk surgeries are supposed to be, the risk is less than 1%. So all superficial surgeries, all lump and bump surgeries, and also breast surgeries and dental, sometimes endocrine surgeries, simple thyroidectomy, and also all eye surgeries, because we get most of the referrals from eye surgeons. They belong to low risk category, as well as some referrals from plastic surgeons, and sometimes you get gynecological referrals, especially the DNCs, and orthopedic minor surgeries, and urological surgeries are considered to be low risk surgeries. I will propose into the high risk group, where you have especially these vascular surgeries, aortic and major vascular surgeries, and sometimes lower limb revascularization surgeries, as well as retroperitoneal surgeries, duodenal pancreatic surgeries, as well as liver resection or liver surgeries, liver transplant, sometimes esophageectomy, and also adrenal resection is a special condition, and also sometimes you see a patient with lung surgeries. So that actually comes as high risk group. Intermediate group is intraperitoneal surgeries, where you get most of the surgical referrals for bowel surgeries and the hiatal hernia surgeries, and the patient who are waiting peripheral arterial angioplasties, and also endovascular repair, and head and neck surgeries, and orthopedic surgery. Even major orthopedic surgeries belong to intermediate risk category, and urological and gynecological major surgeries all belong to intermediate risk category. Renal transplant, yes, it is also intermediate risk category. And sometimes intrathoracic non-major surgeries like lung tumor resection comes as intermediate risk for surgery. So when you go through a patient, you have to assess their past history of revascularization. So especially you get a patient with angioplasty, so you have to get the correct time since the procedure, and which artery angioplastics. Like sometimes they may have had the stent to the left main or LAD, or even main parts of right coronary. Those are actually this morbidity and mortality dependent lesions. So whereas if you see a peripheral lesion which was revascularized, it may not be mortality benefited. And sometimes current medication you have to see, because depending on the time of surgery, they may have changed the medication, as you now listen to Dr. Ransinger's lecture. So usually we give medication 1 to 2 years after the surgery, stenting, dual antiplatelet treatments. And sometimes they have, even though they had surgeries like PTCS, still they may be symptomatic. And also ECG changes, as well as type of stents, also very important, because depending on the type of stents, you have to decide certain things perioperatively. As well as CABG patient, yes, you have to look for the time since the procedure and which artery grafted, as well as the present cardiac medication, as well as their current exercise tolerance, as well as symptomatic benefit. So having gone through that, now you are ready to go ahead your risk assessment. So this is very easy. Even without a cardiologist, as a practicing physician, you can manage 40 to 50% of your referrals. You don't need a cardiologist. It's easy, and stepwise management. First of all, when you see a patient, then you have to decide whether it is urgent or elective surgery, urgency of the surgery. So emergency case, you don't need to do any alteration, or you don't need to do any preoperative assessment. If it is life-threatening condition, then even you don't need to see a physician, like, because then surgeon can do it. But most of the time, the surgeons call this patient needs urgent laparotomy or life-threatening condition. They ask the cardiologist or the physician opinion. But I said, if it is life-threatening emergency surgery, you don't need to see even you don't need to call a physician or cardiologist. You do your surgery, then call us. We'll manage in the post-operative period, right? So there we had to do the post-operative risk stratification, the patient who have undergone emergency surgery. So this cartoon shows the need of non-cardiac surgery. If it is emergency surgery, straight away to the operation theater. And post-operatively, you can do the post-operative risk stratification and management. And if it is urgent or elective surgery, yes, then you have to go to the step 2. Step 2, if the patient has undergone coronary revascularization in the last 5 years or not. If so, if the clinical status has remained stable without recurrent symptoms or signs of ischemia, further cardiac testing is not necessary and you don't need to refer to a cardiologist. Here, the second step, the coronary revascularization within 5 years, yes. If they are not symptomatic, yes, they can straight away go to the operation theater. And if they don't have recent coronary revascularization, yes, then it comes to step 3. Step 3, if the patient who has any coronary evaluation has any in the past, but coronary risk was adequately assessed and the findings were favorable, if it is usually not necessary to repeat the testing. Like now, the patient who had a bypass or the surgery a long time ago, but recent evaluation done, he has good exercise tolerance. Sometimes the patient may have come with CT report or even angiogram that shows very good results. In that case, you don't need to do again cardiology or cardiac referrals. So those patients also can go to the theater, like this category, recent evaluation, yes. And sometimes they come with, as I told you, they come with annual, because most of the time they are followed with annual or biannual stress ECG. So if they have good exercise tolerance, yes, now they can straight away they can go to the theater, right? Then the next step, actually, step 4, the patient. Now from this step onwards, you might need a cardiologist support because they need some more cardiac assessment. If the patient has unstable coronary syndrome, as I told you earlier, if they have major clinical risk predictors, then when there's elective surgery, then you have to actually need some time. And sometimes you may have to cancel or you may have to postpone the surgery. And sometimes if it is not necessary, if it is suppose sometimes unnecessary surgeries where the risk is high, then you can even sometimes you can negotiate with the patient as well as your surgical colleague. And so as I mentioned you earlier, the patient with elective non-cardiac surgery, the patient who have high coronary risk syndrome or high clinical risk predictors, then you have to actually consider angiogram or the further testing. If the patient has other like then subsequently they will come with their reports saying that they have unobstructed coronaries or they have relatively stable coronary status and they can undergo surgery with low or mild cardiac risk. So then only you have to do the proper cardiac assessment. And the other group where you can actually manage in your level, the patient who have intermediate clinical risk factors, where I mentioned they have past MI, but relatively they are stable. They have angina, but that's not limiting angina, and they have compensated heart failure, and they are having a renal disease as well as diabetes who are on insulin. They have risk, the intermediate risk condition. So those patients also, you can, if they are relatively okay, they can actually know clinical predictors, they can straight away go. And then if they have intermediate category, also if they have they have symptoms, like if the functional state is low, then you have to do the non-invasive testing. In that case also you have to refer them to cardiologist before the surgery. So this is what you see, intermediate clinical predictors. If they have poor exercise tolerance, then they might need non-invasive testing. Depending on those results, they might need angiogram or subsequent revascularization. So this category, where they have moderate exercise tolerance with even high surgical risk procedure, then again you have to refer. And the moderate category, if they have intermediate surgical risk, then you can send them to surgery with acceptable low mild cardiac risk. If they have low, then straight away they can go to the theater with low cardiac risk. So step 7, where this non-cardiac surgical patient with minor clinical symptoms, as I told you earlier, if they additional testing is usually not needed, but the patient with poor exercise tolerance might need to go for patient with poor exercise tolerance who are waiting high surgical risk procedures might need to go to non-invasive test. It may be even exercise ECG or dobutamine stress echo, depending on their the capacity. And sometimes you may they may end up with coronary angiogram or revascularization. If this patient with moderate or excellent exercise tolerance, they can straight away go to the operation theater. Sometimes then you have to look them post-operatively and stratify their risk as well as optimize their medical management. So this is last stage, actually, this group where this I already mentioned. So if they have minor or no clinical risk factors with the good exercise tolerance, they can straight away go to operation theater. And that was actually adapted from the American Heart Association. European Society of Cardiology has also given this stepwise approach, slightly different. I'm not going to touch that area because now they are going to give update probably before the end of this year. And hardly any difference, almost similar thing, and but it's a bit complex because they need lot of cardiology referrals. So this is actually I just want to highlight one thing, like the patient who have high coronary risk factors, like then they need to undergo surgery. Like they need to have invasive tests, including coronary angiogram. Sometimes before the surgery we do balloon angioplasty. If they need urgent surgeries, yes, we do balloon angioplasty. Then immediately they can undergo surgery. If you think you can actually by 1 month, then you put a stent. Nowadays the bare metal practice is not very well, so you can put a latest generation stent, and then you can stop your dual antiplatelet treatment just after 1 month and send them for surgery. And CABG patient, ideally you need 1 month stabilization before you send them for major surgeries. Okay, so ladies and gentlemen, now I have come to the last part of my talk. So many patients, actually, as we know, most of the patients they come to the first, they come to you as their first opportunity to see a cardiac assessment because of their non-cardiac surgeries. They never come to the surgeon, and they never come to cardiologist or physician before other than this surgical intervention. So cardiologist or physician serves the patients by aimed at lowering the immediate post-operative cardiac risk. And also they should assess the need for post-operative risk stratification and intervention directed to modify the cardiac risk. And careful teamwork and communication between patient, physician, anesthesiologist, and cardiologist and surgeon is also needed. So ultimately that will increase the outcome. So indications for cardiac testing and treatment are the same as in the non-operative settings and should clearly affect the patient management. Factors include the urgency of surgery, patient-specific risk factors, and surgery-specific risk factors also should be considered before you do preoperative risk assessment. Thank you.
Thank you, Roshan, and all four speakers for their excellent talks. The next session is question and answer session. May I invite Dr. Upul Disanayake, the consultant physician, to the head table as a moderator. And also, I will invite all four speakers come to the front seats. And for the virtual audience, we are kindly inviting you to send your burning questions to the Zoom chat box, and the panelists will be happy to answer your questions. Thank you.
The first question goes to Dr. Dunuvilla. Now you mentioned that there's the syncope could be two things, the arrhythmic syncopes and the vasovagal syncopes. How do you clinically differentiate between the two?
Thanks, Upal, for that question. Well, vasovagal syncope generally is a process which happens very quickly and very common in the younger age groups. So, for example, if a child has a syncopal episode at the assembly, that's the classic feature, where the child generally feels it coming and then on the ground for a very short time and soon afterwards gets up. So that's the classic picture. Now, as opposed to arrhythmic syncope, where the patients will have a drastic syncopal episode, can suffer injuries and the recovery can go over a longer period of time. Those are the basic differences. Of course, there can be overlaps, but that's the classic difference.
Thank you. Thank you very much. So this is probably the pre-op assessment. The new, is it for Gotabe? The new antiplatelets. Say when you plan a surgery, how many days that you need to be off antiplatelets before the surgery? Probably Gotabe. Roshan, yes, Roshan, yes.
Yeah. So elective surgeries, you have time to decide. But most of the cases in emergency surgeries, you get a patient who have been on novel antiplatelet treatment comes with life-threatening conditions. So there you have to correct with the FFE or the factor 10 levels. Then they can undergo the surgery irrespective of their underlying cardiac condition. But if you think the patients have elective surgery and they have some time, like 1 week time, then you can stop novel antiplatelet treatment for 1 week and bridge the gap with either aspirin or the other treatment, then do the surgery. Ideally, you have to wait for 72 hours minimal, but elective surgery is better to have 1 week.
And extension to that answer, actually we get a lot of referrals for stoppage of antiplatelet therapy for certain surgeries. They are like dental extraction and the cataract surgery. I think for those surgeries, you don't need to stop, ideally. And especially cataract, and especially patients who had undergone PCI and having stented. So, I mean, we find sometimes very difficult to handle them, and then especially within first 3 to 6 months. So if someone of that nature would go for dental extraction or cataract, I don't think you should stop any of those, and you don't need. But unfortunately, due to some reason, we get all the referrals whether to stop or not.
Got to be same way. Now, if the patient has had the stent recently and is on dual antiplatelets and going for a surgery, do you now can you stop any of them, and when can we sort of think of doing a surgery after say stent?
Yeah, that's a good question. Actually, all depend on the surgery. So suppose it's an urgent surgery, definitely you have to embark upon. There's no question if it's the emergency surgery. So, and but it's, I mean, it's elective. Of course, now we can stop dual antiplatelet after 1 month. There are certain stents now, and so after 1 month you can stop and go for the surgery if it is really deemed necessary. And I think best thing is, if it is an elective surgery, best thing is to wait for at least 3 months. So after 3 months, you can stop and go for surgery and then restart as soon as possible. And so that's a scenario. So, but if it is semi-urgent or urgent, I would say, so you stop it and do it. And still, if you can wait for at least 1 month, the best.
Do you cover that period with enoxaparin, or you just leave it without anything?
No, you don't need to. You don't need to.
When you cover with enoxaparin, the risk is more. They say not to, even the ESC guidelines say not to cover, not to bridge with enoxaparin for any reason.
Now, this for sometimes these people are detected to have hypertension when they go with headaches. Somebody, a girl gets a migraine attack, she goes to the GP, they detect high blood pressure and they treat with antihypertensives. Is there a cutoff point where you get a headache with high blood pressure, or is it a relative thing?
No, it's like this. From my experience, I mostly think most of the people now, hypertension is, you can get the high blood pressure, not the hypertension actually, high blood pressure, elevation of systolic blood pressure with any nervous response, right? Any systemic disease, even the headache, pain is a known cause of elevation of blood pressure. So most of these girls, especially younger population, without having significant risk factors, they are coming with different sort of things, and because even the anxious person, that itself can elevate the blood pressure. So when that situation, if you detect blood pressure, I think the best practice is not to treat at that point unless you have evidence. Say for example, if you have a target organ damage, so that's a definite clue to treat for that type of patient. But otherwise, if you have a systemic disease, if you have headache, if you have any other pain syndrome, if you are in anxious situation, best thing is to delay. And these are the people really needs out of office blood pressure measurement once their problem recovers, rather than jumping and treating on hypertension. As for the first question, whether you have a cutoff, definitely not. But if you take pathophysiology, for you to get headache due to blood pressure, that has to affect, say like cerebral edema, cerebral encephalopathy, that type of response. But I do know that some patients says that I had blood, especially elderly population, I got a headache, I checked the blood pressure, it was high. There may be relationship, but I don't know how to explain it. But basically in a younger population where you don't find any risk factors, I don't think you need to treat for that hypertension without properly investigate later on, especially with out of office blood pressure measurements.
Thank you. What is the indication of for antiplatelets in primary prevention of acute coronary syndromes? Is there a place for aspirin?
I mean, that's a very difficult question, but thing is like, now let's put it this way. And primary prevention of coronary artery disease, or primary prevention of, or rather prevention of heart attacks. And so that all depends on the risk profile. But at the moment, aspirin is not strongly indicated to prevent acute coronary event, unless the person got a high risk profile. And suppose somebody comes with diabetes and hypertension, smoking, strong family history, And so, I mean, those patients, of course, though the person has not developed any cardiac event, I would suggest, but still after 40 and not very early. So the data, I think the evidence is not that strong. And for primary prevention of acute events or heart attack for those people. And but secondary, yes, always. But well, you know why? Because the risk data, more and more data accumulating, because if you give them aspirin, the complication of aspirins, as bleeding, is much more, outweigh the risk the more than the benefit.
Asang, now somebody is asking the management of WPW related acute arrhythmia, because some of the drugs like digoxin and verapamil are contraindicated. How do you, what is the response for that?
Yes. In acute management of WPW arrhythmias, it's like you can't use primarily AV nodal blocking drugs because it gets arrhythmia gets accelerated along the accessory pathway, leading into faster antegrade tachycardia and subsequently AF. So AV nodal blocking drugs during the episode of tachycardia is strictly discouraged. So in which case verapamil and adenosine should not be used, especially if it is a wide complex tachycardia. Suppose if it's a narrow complex and it presents like a standard SVT, yes, you can use the drug. And then, of course, it stops at the AV node level. Those are the retrograde tachycardias, but not the wider complex tachycardia, in which case either you will have to cardiovert or you have to use one of the class 3 agents like probably flecainide or amiodarone is a little slow, but can be used if the patients are stable and the rates are lower. So the best thing is to do a cardioversion at that time.
Thank you. I think we are running out of time. Gotabe, now there are these patients who are on warfarin for other things like, say, the DVT prophylaxis. When they come with the myocardial infarction, you wonder whether you should give the aspirin and clopidogrel, or especially if they have unstable angina sort of picture. How do you approach that problem?
Of course, I highlighted some points in the lecture as well. But if they come with, I mean, suppose somebody comes with acute event, acute coronary event, but on warfarin, of course you have to maintain, give the same treatment. So loading doses of aspirin and clopidogrel, and or even any other agents, newer agents. But make sure that once the procedure is done, and so whether how long are going to continue, all these three agents. And so now the evidence is more in favor of newer anticoagulant agent. If at all then the patient was on warfarin, so change over to the apixaban or rivaroxaban, and then continue. Maybe you continue triple therapy maximum for 1 month. And after 1 month, now newest study shows 1 month after that actually you can stop aspirin and go with dual antiplatelet. And so then after 1 year, so you can jolly well continue with anticoagulant agent, especially if it is a newer agent and like apixaban or rivaroxaban. But of course, we in our practice we have still warfarin, but still you can continue warfarin.
Thank you very much. And yeah.
Now we have come to the end of the session, and may I invite Dr. Upul Disanayake, the moderator, to hand over the certificates of appreciation. Dr. Asanga Dunuvilla. Dr. Gotabe Ranasinghe. Dr. Sampath Vithanavasam. Dr. Roshan Paranavan. Now we have come to the end of this session, and thank you for joining with us online, and all for all 4 speakers and the staff of the ClinMark and the CCP staff, and also the our sponsors as well as the audiovisual team. And a special thank to Dr. Anindhu Patirana and the Sri Lanka College of Cardiology for collaborating with CCP in this month. And anyway, we'll be having other events as well with the collaboration of Cardiology College. And thank you so much.